Thank you for the opportunity to present at the 17th World Congress of Anesthesiologists. We were meant to meet in Prague. I'm Rocky Daly. I'm the Surgical Director of Heart and Lung Transplantation at the Mayo Clinic in Rochester, Minnesota. I have nothing to disclose. This is our outpatient areas at the Mayo Clinic in our small city of Rochester. And one of the two hospitals, this is St. Mary's Hospital, where all of the cardiac surgery is performed. We're located in the middle of the country and up north. And we are quite a ways away from South Africa, where the first heart transplant was performed in 1967. This is one of the operating room pictures. It was by Dr. Christian Barnard, as you know. And the patient on the left here was in the survived 18 days and never left the operating room. That became his intensive care unit. And there was a lot of excitement about heart transplant, but the outcomes were poor initially. Among the first 100 patients having heart transplant around the world, really none of them lived a year, which caused Sir Royal Collin to say, "Modern immunology has been driven and owes its scientific preeminence to the rash behavior of ignorant surgeons." Of course, things turned around with time, primarily related to the use and understanding of cyclosporin in the early 1980s. At the Mayo Clinic, we've done more than 700 heart transplants since our program was started in 1988. Our indications are very similar to most other programs, with ischemic and dilated cardiomyopathy being predominant, but we do have more experience with both amyloid and congenital heart diseases in our particular practice. This is one of our patients with congenital heart disease who had situs inversus dextrocardia and in whom the chest x-ray looks like this after heart transplantation. This was one of our pediatric patients, donor heart, that the patient had hypoplastic left heart syndrome, and the donor is quite small. Well, I thought I'd mention a couple of things regarding what's new in heart transplantation, particularly in affecting our practice. Monoclonal antibodies have been around for at least 3 decades now, but the numbers have increased, and our understanding and evolution of the use of these has been increasing with time. I won't go through all of them in detail, but here is a schematic that illustrates the activity of some of the monoclonal antibodies that we have learned to use in transplantation. Alemantuzumab is an induction agent that many use. Rituximab blocks CD20, which decreases B-cell proliferation in patients with antibody-mediated rejection, and eculizumab is a powerful inhibitor of complement, which has saved lives, but is also a very powerful drug. At our institution, we have advocated more use of sirolimus for maintenance or late immunotherapy. The limitations to survival after heart transplant related to the graft are graft failure and allograft vasculopathy, and other comorbidities that affect survival over time include infection, renal dysfunction, and malignancy. Conversion to sirolimus can impact a number of these. We've shown a reduction in graft vasculopathy, which I'll show you, and it can help with preserving renal dysfunction by reducing calcineurin inhibitor dosing, and we found a reduction in malignancy, which I'll show you. This is cardiac allograft vasculopathy 5 years after transplantation, and these are several articles that we have published showing conversion to sirolimus after heart transplant will reduce cardiac allograft vasculopathy. Here is incidence and development of plaque volume over time after heart transplant in coronaries, and you can see that it is much more prominent with the use of calcineurin inhibitors such as tacrolimus and cyclosporin compared to sirolimus. We've shown a decrease in all-cause death and cardiac death over time in patients that have been maintained long-term on sirolimus. This is a pulmonary malignancy after heart transplantation, and we've recently shown that malignancy after heart transplantation is decreased with sirolimus. And in this review, again, we showed improved survival, late survival, among patients maintained on sirolimus compared to those maintained on calcineurin inhibitors. Well, multi-organ transplantation is getting more common, and this is one of the recent journals of heart and lung transplantation in which the focus of the theme focus was on multi-organ transplant, indicating increased predominance over time. Heart-liver transplantation in the United States is definitely increasing, and among these, this is the portion that we have done at our institution. We have experience with 58 combined heart-kidney, 50 heart-livers, and among these, 5 of them were combined heart, kidney, and liver. This is one of the patients with a pre-op chest x-ray. This patient had a complex congenital heart disease with 4 previous sternotomies and Fontan, and the post-transplant x-ray on the right. This was her native heart and her native liver, Fontan-associated liver disease, and the donor heart and liver arriving in the operating room. And this is the picture after the heart and liver transplantation. As I mentioned, we've done 50 combined heart and liver transplants, predominantly for congenital heart disease and for familial amyloid. And among the familial amyloid, domino transplant of the liver was performed in 56% of the cases. We had 1 operative mortality in this group of 50 patients, which I'll come back to. This is survival after heart and liver transplantation compared to isolated heart transplantation and compared to isolated liver transplantation. And you can see that the combined patients compare favorably, which I think helps to justify this procedure of 2 organs. Patients do stay in the hospital for a longer period of time. Much of this is related to rehabilitation, and even among the amyloid patients, they have a neuropathy and GI dysfunction, which slows their overall rehabilitation. Most of the patients have conventional surgery, that is, implanting the heart before the liver. That was 43 of our patients. We've learned a little bit over the time. This is an example of a 66-year-old who had a straightforward heart-liver transplant for familial amyloid. But you can see with the surgery, he's positive 20 liters and negative 10 liters, or a balance of nearly 10 liters positive with the surgery. That is a lot to ask a donor heart to do after an ischemic time. So we've learned to work to protect the cardiac allograft from overdistension and review this with our liver anesthesia team because they take over after the heart transplant. We're aggressive early to treat any RV dysfunction with nitric oxide, a prostadil, and 1 patient required an RVAD. And we work hard to keep the RA pressures low and not overdistend the right ventricle. During the anhepatic phase and liver reperfusion phase, we have a cardiac surgeon in the operating room, and we keep the bypass tubing and the pump available at the table for establishing bypass if we have troubles. This is not very common, but when it happens, when the patient becomes unstable with reperfusion, it's useful to have bypass ready. Our single death was in a patient that developed systemic intravascular thrombosis after veno-veno bypass from the liver transplant. This patient had amyloid disease, so normal liver function, and normal coagulation after heart transplant and bypass. By the heart protocol, we continued the Amicar infusion, but by the liver protocol, no anticoagulation was given for veno-veno bypass because most of the liver patients are auto-anticoagulated. So we've learned to maintain anticoagulation for the veno-veno support, and also to stop or avoid antifibrinolytics in these patients. We recognize that there is much less rejection after combined heart and liver transplant compared to isolated heart transplantation. This shows the increase in donor-specific antibodies prior to heart transplant and following isolated heart transplant. But among the patients that had combined heart and liver transplant, while they had more donor-specific antibodies prior to transplant, they did not develop more over time. And we also noticed less cardiac allograft vasculopathy compared to isolated heart transplant for the patients that had combined heart and liver transplantation. Which brought us to revising our surgery for a few patients who are highly sensitized with antibodies. In 7 patients, we performed the transplant with the liver implant prior to the heart transplant in order to help reduce donor-specific antibodies. We published our experience with this just this year in JACC. This shows donor-specific antibodies which were high prior to transplant, and over time they come down and they become really non-important over time. So among these 7 patients, all had preoperative donor-specific antibodies, so they all had a positive virtual cross-match. And this means antibodies with an MFI more than 4,000. The prospective cross-match was positive in all of the patients, but retrospectively, after the cross-match, after the transplant, the cross-match became negative in all of the patients. In follow-up, we have had no treated antibody-mediated rejection and no treated cell-mediated rejection among these patients who were highly sensitized. Finally, just a word on combined heart and kidney transplantation, because we've learned that there is an impact of vasoplegia on the renal allograft. This is the renal graft survival in patients who developed vasoplegia compared to those who did not have vasoplegia after the transplant. And you can see that the vasoplegia impacts graft function, and it's mainly early on. When we looked at the potential causes of vasoplegia, the only thing that came out in our group of 58 patients was that patients going to transplant, needing heart and kidney transplant, who are bridged with an LVAD, had a higher incidence of both vasoplegia and poor renal function after the transplant. But vasoplegia can be anticipated in some other cases with very high filling pressures on the venous side pre-operatively, may be more prone to vasoplegia. And it might be extrapolated to be careful about selecting these patients for the combined surgery. So in conclusion, good results are feasible with combined heart, kidney, and combined heart liver transplant, but careful recipient and donor selections necessary. We've learned that the liver provides very important immunologic advantage to the heart, and the perioperative management requires attention to fluid administration and RA pressure. Anticoagulation during liver transplant is important if the liver synthetic function is normal, and consider the potential of vasoplegia in patients who are being selected for combined heart and kidney transplantation. I'll finish with a picture of one of our patients arriving in San Diego Harbor after sailing around the world after he had undergone heart and kidney transplantation. During his trip, he was advocating for organ donation.